Presently, there are a number of unmet needs still in the area of CINV. Probably first and foremost is really delayed nausea. We know that from the acute nausea and vomiting side, with the 3-drug regimens and highly metagenic chemotherapy, that we have gotten complete response rates well into the 90% range, which means basically 1 out of every 10 patients therapy will fail, where in years past this was close to 5 out of every 10 patients. So we've done a very good job in the acute nausea and vomiting area. For delayed nausea and vomiting, though, there's still this underreporting, and there's a number of research studies have been done to really try to drill down as to why patients have a hesitancy to report their delayed nausea and vomiting. And seems like there's a number of reasons for that, most of which patients don't want their physicians to stop their chemotherapy. Again, they think that if they report their nausea and vomiting, that it must mean the chemotherapy is not working. We know that that's not true. So there's that unmet need, and really looking at, again, at what's the most effective therapy for delayed nausea and vomiting. I don't know if we have the answer to that question yet. Secondly is breakthrough nausea and vomiting. And this is a hard population of folks to get into a clinical trial setting because when it happens and how quickly it happens, they're hard patients to quote-unquote randomize to a clinical trial. So we really need to do a better job of trying to obtain data to see what is the best combination of agents, or what's the best sequencing of antiemetics in order to treat breakthrough nausea and vomiting. And then last group is the refractory patients. These are patients that don't respond to preventative medication up front. And again, this is a very hard group of patients to treat. There's very little data out there to help us, guide us in what's the best way to prevent their nausea and vomiting. There's no predictive models, or at least good predictive models out there, looking at folks that we know up front are going to be really difficult and really going to be refractory to standard antiemetic therapy. Another area of unmet need is multi-day chemotherapy. As previously, when we talked about those definitions of MEC and HEC, low and minimal chemotherapy agents, those are really based on older single-day regimens. Today we know that we use a lot of multi-day, multi-agent regimens, and the treatment or prevention of CINV for the multi-day regimens are not really adequately defined. There's very limited randomized data suggesting what to do with multi-day regimens. We know, and currently the guidelines recommend to give the same antiemetics on all days of chemotherapy. Whether that's the right thing to do or not, we're still trying to determine. Particularly when you talk about 5-day cisplatin. So if you're giving somebody 5 days of cisplatin and they have emesis on day 3, is that acute nausea and vomiting or delayed nausea and vomiting? And the answer is probably a little bit of both. And so we need to really drill down what to do with these multi-day, multi-agent chemotherapy regimens. When determining our antiemetic regimen in a preventative setting, we also need to consider the antiemetics themselves from a safety profile, and more importantly, a drug-drug interaction profile. From a safety profile, these agents are fairly well tolerated and have minimal differences amongst the agents. Certainly we know that headache can be a problem with the 5-HT3s. Constipation or diarrhea are really the 3 major toxicities that we'll see with them.